The first question is, what's the role of platelet transfusion in severe adult dengue with thrombocytopenia? And what is the cutoff point of platelet to transfuse? The second part of that, Prof. Terapong, is there any role of steroids in managing myocarditis that's due to severe dengue in adult patients? Prof. Terapong?
Thank you. Thank you. Can you hear me? Can you hear me?
Yes.
Thank you.
Yes, we can hear you. Thank you.
So for the question about the thrombocytopenia, usually we are afraid when the platelet is lower than 20,000. But if they have the asymptomatic or no bleeding, we don't use the platelet, definitely. But in case that they have the active bleeding, maybe less than 50,000, we will use the platelet transfusion. However, in some practical in Thailand or maybe in our guideline that recommended by the hematologists, they said that if in the liver failure patient, because you know that acute liver failure, they may have the more bleeding because they have the other problem in the coagulopathy. So they will use the platelet transfusion. Also, they have no bleeding if less than 20,000. The other question that the steroid, usually we use steroid only one reason for the dengue in adult, only when they have the HLH. Okay, only they have the hemophagocytic, lymphocytic, erythrocytosis. Okay, only this one condition that we use. For myocarditis that I told you, the CBK maybe increase around 50%, but usually they have no symptom. Usually they have no symptom, except some may have arrhythmia, some may, very rare case that we found the profound cardiac shock. Thank you.
Okay, thank you very much. All right, the next two questions are for Lucy. The first part of it is the role of CVP in assisting fluid management of dengue shock syndrome in children. And the second part is the role of echo in looking at IVC collapsibility in assisting fluid replacement in dengue shock syndrome in kids.
Okay, so regarding the central venous pressure monitoring, it can be done, but it's going to be quite tricky because you have a bleeding scenario, and in a patient who is very hypovolemic, it's not easy to insert a central line. So it's going to be challenging. But of course, nowadays with the ultrasound guided and all that, I'm not in that realm where I'm happy to put in a central line for a hypovolemic dengue shock. But of course, if they are already hypervolemic towards the end of their plasma leakage phase, where they do need a central line for hemodialysis or renal support, then that's not difficult to put in a central line at that point. So I think that you have to weigh it carefully. I would not do it as like a standard. Your skills got to be really good and you can't miss it, because if you miss it and then later on it's going to bleed quite torrentially. So generally we don't need it because there are other parameters like non-invasive, like using an ultrasound, looking at the IVC, the collapsibility of it. And but however, the interpretation can be quite challenging, because you need to see whether the patient is ventilated, the patient is acidotic, because the way the patient breathes will affect the collapsibility of the IVC. Changes in the intrathoracic pressure because of the acidosis, that may affect the IVC collapsibility. So I think that it's not just looking at the IVC say and then making a decision. We need to kind of look at the whole picture of the child and then make a decision based on that. So yes, if you said a non-invasive, it's useful, but you must know how to interpret it. Yeah. And once you give the fluid, and then if should you need to intubate, and then that's the whole dynamics change, and you have to interpret that IVC in that context of the positive pressure that you are putting in the thoracic cage and all that. So it's not easy to interpret, but can be done. Yes, I do it. So it's fun. Like I said,
you do it?
I do it. I use the IVC, but like I said,
okay,
it's non-invasive, Yeah. And sometimes when there's a lot of fluid, you can't find it where the IVC is. Okay, so not so straightforward. Yeah.
Lucy, this is just for you. You know, somebody asked whether there is any role of NAC in children with severe liver involvement.
Oh, a role of?
NAC.
Oh,
NAC.
N-acetylcysteine. Oh, okay. Personally, I don't use it even when there is liver failure. I mean, well, it depends on how severe the enzymes are. We do know that they're all kind of, if we improve the perfusion, do not overload, because when we overload your patient with a lot of fluid, the pressure, the venous pressure increases. And when the venous pressure increases, the total perfusion pressure to the organ actually decreases. So if we keep on loading the patient, so you can find that it's actually counterproductive. So it's important to avoid that overload of fluid. And using N-acetylcysteine actually involves quite a lot of volume. All right, so it's volume. So you will be loading the patient with volume again. So you really have to weigh the pros and the cons carefully. But on general, I mean, of course, there is no evidence, no evidence-based medicine, but generally I prefer not to use unless there is, documented paracetamol toxicity. Then I think that there is a place for N-acetylcysteine. But if we are talking about dengue per se, and your paracetamol levels are still kind of like not too in the toxic range, I think it's better to play safe and then just go on your careful fluid and the blood to control any bleeding, and then get the patient out without causing too much volume overload, because that will just compound the organ impairment.
Okay, Professor Chirapong, would you like to add something? Because I know in adults you have a lot of dengue patients with liver failure and may cause death. NAC, NAC.
I think that our chairman and Professor Sombat and Professor Natachai try to save life the patient who had the acute liver failure. I think now it's maybe nearly 10 patients. And I think that someone we can keep the patient, because 5 years ago when we had the patient who had the acute liver failure, all of them die. Okay, I think that we hopeful that the NAC that Professor Sombat think that in the acute liver failure it may some help. Okay, and the SPAT or maybe the other detoxification is maybe important, such as someone try to use the plasmapheresis, something that I think it may help, but the event base is maybe not easy to get it, because the severe case is not uncommon.
Thank you. So,
thank you.
Professor Zhu, would you like to close, please? Because you do the opening, so you do the closing too, please.
All right, thank you very much. Prof. Usa has been reminding me that we'll be on time. And I'd like to end the session. And before that, I'd like to thank all of you for attending this. And then, of course, the three speakers, Lucy, Prof. Terapong, and Prof. Wills. And I'd also like to thank Takeda and Foundation Miru for their educational grants that made it possible for us to have this session today. And of course, the ideas and action from the Advisory Committee, the Global Dengue and Aedes Transmitted Diseases Consortium, or GDAC, and also the International Society of Neglected Tropical Diseases, or SNTDC, who have collaborated with us all this time. So thank you very much for your time, and we hope that it's been beneficial. And see you at the next one, which will be sometime in end of March or early April, and then the other one on the 15th of June.